Good evening. We have a very interesting session. Some of us are here, some of us are going to be connected online. And we will start with the first presentation from Dr. Juan Pablo Kaski from the UK, Cardiomyopathies in Children Evaluation and Risk Stratification. Professor Kaski.
Thank you very, very much. I hope everyone can hear me. Thank you for the introduction, and thank you in particular for inviting me to this this Congress. It's a real honor and a pleasure to be here. I hope everyone can see my screen. I'm a pediatric cardiologist, and I guess that most people in the audience are more used to seeing adults with cardiomyopathies and heart muscle disease. So what I'd like to do today is just tell you a little bit about how we assess heart muscle disease cardiomyopathies in the pediatric population and how we manage them. And I think the first thing to remember is to recognize really is that children aren't just small adults. So as these authors in Archives of Disease in Childhood have said, it's time to acknowledge that both children and adults belong to the human race. And I think in the cardiomyopathy world, this is particularly relevant because we're talking about conditions that affect the entire life course of an individual. So this is the example of dilated cardiomyopathy, but you can put up diagrams that are exactly the same for all of the different types of cardiomyopathy. And so what I'd like to do is to debunk some of the myths or paradigms that exist around pediatric cardiomyopathies. And I'll do this by focusing on three different aspects. So the diagnosis, screening, and clinical management, in particular risk stratification. So we define the cardiomyopathies in the pediatric population in exactly the same way that we do this in adults. So it's a morphological description of the heart. So hypertrophic cardiomyopathy, thick heart muscle, dilated, enlarged, baggy hearts with reduced function, and so on. And this is really the beginning of the diagnostic process. These in themselves are not diagnoses, but rather they are an initial description. We then go on to subclassify the cardiomyopathies into familial or genetic and non-familial, non-genetic causes, and from then on into individual disease subtypes. And in the pediatric population, actually the etiology of cardiomyopathies is very heterogeneous, much more so than we see in the adult population. So in a substantial minority of patients, particularly those diagnosed in the first year or two of life, there are conditions that can cause hypertrophic cardiomyopathy that are also associated with other organ involvement. So these are metabolic disorders such as glycogen storage diseases, malformation syndrome such as Noonan syndrome and related conditions, neuromuscular disease, particularly Friedreich's ataxia. And so this is an example of the sort of thing that I guess we see in the pediatric world that we perhaps don't see so much in adults. This is a 3-month-old presenting with signs of congestive cardiac failure, first child of consanguineous parents. That's the ECG, which shows huge left and right ventricular voltages, extremely abnormal repolarization. And these are the echocardiographic pictures. So this is extreme left and right ventricular hypertrophy, very little in the way of a cavity. And putting all of this together, this is an autosomal recessive family tree with parental consanguinity, extreme ventricular hypertrophy, also some extracardiac features. This is an example of Pompe disease. And I guess this is what a lot of people have in mind when you think about the sorts of conditions that we see in the pediatric population. And it's important to make these diagnoses because, as we'll see later on, there are potentially disease-modifying treatments for some of these conditions, but also in particular, we know that the outcomes are different according to the different etiologies. So these are data from a UK pediatric hypertrophic cardiomyopathy study that we published last year. Very similar situation in dilated cardiomyopathy, very heterogeneous group of etiologies, familial and non-familial disease, and also very different outcomes according to the underlying etiology. And if we focus particularly on the prevalence of familial disease or the reported prevalence of familial disease, we can see that in the literature, actually familial disease in pediatric cardiomyopathies is reported in a minority of patients. These are data from the North American Pediatric Cardiomyopathy Registry showing a prevalence of only 5% of reported familial disease. So this is my first sort of paradigm and myth that I want to debunk, and that's that familial genetic disease is reportedly very uncommon in pediatric cardiomyopathies. In fact, we know that's not the case. So many years ago, we published our data on pre-adolescent hypertrophic cardiomyopathy, so children diagnosed with hypertrophic cardiomyopathy before the age of 13. And we found that 2/3 of these patients had familial disease, and over 50% had mutations in the cardiac sarcomere protein genes, so exactly the same sort of mutations you see in adults with hypertrophic cardiomyopathy. And this was the case across most age groups. So even in infancy, a significant proportion had familial sarcomeric disease, but outside infancy, it was the predominating etiology. And we're now, with new techniques, are now starting to see exactly the same thing emerging in the other forms of pediatric cardiomyopathy. So data from Europe and from North America on dilated cardiomyopathy, showing a yield of between 30 and 50% of genetic familial disease, the usual suspects, sarcomeric disease, lamin, filament C, etc. And increasingly also evidence emerging of a similar pattern with arrhythmogenic cardiomyopathy. So these are data from Dominic Abrams' group in Boston. So this leads to the next question, really, which is, can genetic testing help in the diagnosis of pediatric cardiomyopathies? So let me show you a case. So this individual here with the red arrow is a 14-year-old referred to us for family screening following the diagnosis of hypertrophic cardiomyopathy in his father. His father has a pathogenic troponin T variant, very well recognized mutation, and has relatively mild left ventricular hypertrophy, which fits with this particular pattern. This is the ECG and the MRI of our patient, our teenager. So ECG shows some subtle repolarization abnormalities in 1 and AVL, but really not much more than that. And there's no evidence of left ventricular hypertrophy on his cardiac imaging. But on a 24-hour tape, he has a short run of broad complex tachycardia, a non-sustained VT. So we went on to perform predictive genetic testing in this child, and he does indeed harbor the familial troponin T mutation. So does this child have hypertrophic cardiomyopathy? Well, he doesn't have left ventricular hypertrophy, but actually he does have a number of other features which are definitely relevant in the context of the genetic mutation and in the context of the family history. And so I think this is a case that I think highlights the fact that we shouldn't focus on a single parameter when we're talking about a diagnosis of heart muscle disease, but it's important to take everything in context. And I think this leads nicely to the second myth that I'd like to debunk, and that's that, okay, when it's not these really rare things like Pompe disease, actually pediatric disease is just very early, mild form of adult disease. So here's an example. This is an 11-year-old, completely asymptomatic, pathogenic beta-myosin heavy chain mutation, very strong family history of hypertrophic cardiomyopathy, sudden death and progression to heart failure. This is the ECG, very abnormal ECG, and some stills from the cardiac MRI, including the demonstration of significant late gadolinium enhancement. So this is not mild disease. Actually, this is what we see not infrequently in the pediatric population. Here's another example. This is a girl, 15 years old, referred for family screening following the sudden death of her father, reportedly from hypertrophic cardiomyopathy. This is her echocardiogram, which clearly shows no evidence of left ventricular hypertrophy. In fact, if anything, the left ventricular walls are relatively thin. This is her ECG. It's not normal. The voltages are very low. There's very little in the way of atrial activity. But this is not the ECG that you expect to see in hypertrophic cardiomyopathy. This is what happens when she gets on the treadmill. Even before she starts, she develops this sustained ventricular arrhythmia. And on 24-hour tapes, we see short runs of atrial tachycardia. So this girl has a phenotype, but it's not the phenotype of hypertrophic cardiomyopathy. So we perform genetic testing, and actually we identified a pathogenic lamin variant, which explains her phenotype. But how does this fit with the rest of the family? So, in fact, at this point, we were then able to get hold of the post-mortem report on her father, which in fact did not show any evidence of left ventricular hypertrophy, but did show significant left ventricular fibrosis. So this again highlights the importance of looking at the information in the context of the family history, but also involving all of the information that's available to us when we make these diagnoses. And I think this leads on nicely to the second bit of my talk, which is in relation to screening. So we know from a number of different publications that the clinical utility of genetic testing, but also for clinical screening, is primarily in relation to providing reassurance to family members who don't carry the familial mutation. So you can screen them and you can discharge them from clinical care. And this is an established class 1 indication for all types of cardiomyopathy in adults. But in children, the current guidelines do not recommend screening below the age of 10 or 12, if you follow the American guidelines, unless there are certain high-risk features. So no routine screening below the age of 10 or 12. And this is because familial disease has been reported rarely, but as we've seen, this isn't really the case, it's just an underreporting. But also because there are a number of studies that have suggested that in familial disease, particularly in hypertrophic cardiomyopathy, left ventricular hypertrophy is not reported to develop until the later teenage years. And more recent data looking at the potential penetrance of sarcomeric disease again has suggested that sarcomeric mutations do not present in adolescence or before adolescence. So here's the third paradigm. There's no need to screen for cardiomyopathies in childhood because they just don't present in that age group. The problem is that if you don't look, you won't find. So if we look at the Barry Maron's study from the 1980s, looking at the prevalence of left ventricular hypertrophy and familial disease, actually you'll see that very few of these patients were aged under 10 or 12. So of course, if you don't look in young children, you're not going to find it. And even those that were screened below the age of 10, actually the majority of them already had left ventricular hypertrophy. So the disease was already there. And similarly with the penetrance study, there are no patients aged under 10 in this study. So of course, you don't look for disease in young children, you won't find it. But in our experience, it's there. So these are data that we published last year, looking at over 1,000 patients from nearly 600 families, all pediatric first-degree relatives of individuals with hypertrophic cardiomyopathy, referred under the age of 18 for screening. And what we found is that in nearly 10% of these families, we were able to identify evidence of disease in childhood. You'll see from the histogram that the age range at which this happened was very widespread, but it really includes all age groups. And if we had just followed the European or the American guidelines, actually over 25% of these, over 75% of these patients rather would have been missed. In our cohorts, the mean age of diagnosis here was 10 years, and importantly, making the diagnosis resulted in an intervention in over a third of patients. So disease is there. We know also from recent data published by Dr. Lorenzini and colleagues together with our group, that it doesn't really matter how old you are when you start screening. The penetrance of the disease is exactly the same. So this concept that there's no need to screen below a certain age is in fact not true, and there may be other parameters that are more important to look at, for example, the 12-lead ECG. So then just very briefly moving on to management, and in particular risk stratification. So you'll know that particularly for hypertrophic cardiomyopathy, there are really well-established risk stratification models, risk prediction models that we can use to give an individualized estimate of risk of sudden cardiac death. Now, these models, which are incorporated in European Society of Cardiology guidelines, have a number of caveats, most importantly of which is that it has not been validated in under 16s. And in fact, there are very limited data in under 18s in these cohorts. We can't really use it in children and teenagers. So at the moment, the guidelines from the international societies are really based on very old data extrapolated from adults. So in the American guidelines, you need a single, what they term major risk factor, syncope, LVH, family history of sudden cardiac death, and that's enough to warrant an ICD. In the European guidelines, you need 2 of the conventional risk factors, so they're the same as those in the American guidelines with the addition of non-sustained VT. So these are the current recommendations, but actually, do they work? So this is, again, the final paradigm that sudden cardiac death risk in children with hypertrophic cardiomyopathy can be assessed simply by extrapolating adult data. So we looked at this last year in a UK cohort, and whilst we found that, yes, those with more risk factors were more likely to have a major arrhythmic event, the majority of children and teenagers who die suddenly from hypertrophic cardiomyopathy actually have zero risk factors or possibly one of the conventional risk factors. And so the positive predictive value and the C statistic of the current approach is very, very poor. So we can't really use this. So in order to try to address this, a couple of years ago, we established an international pediatric hypertrophic cardiomyopathy consortium, which was led by Gabby Norrish, who's one of my PhD students who was leading on this work. And this involves data from over 40 centers across the world. And we published our initial results last year. This is a novel risk prediction model for sudden cardiac death in a pediatric population using predetermined clinical parameters: maximal wall thickness, left atrial size, syncope, non-sustained VT, left ventricular outflow tract obstruction. And we were able to show that this model actually predicts risk of sudden cardiac death at 5 years reasonably well, so very similar statistical values to those that we have in the adult model. And we're now in the process of externally validating this and seeing if we can refine it by adding additional parameters. So far, the way that we manage cardiomyopathies has really been this sort of thing. So identifying individuals at risk of complications and trying to prevent those, treating symptoms where they're present, but our treatments really have been unchanged for decades. But I think in pediatric cardiomyopathies, actually, we have an opportunity here to move into a much more sort of personalized medicine sphere. And in a way, we've been doing this for a little while. So, for example, there are enzyme replacement therapies for Pompe disease that we know, when given early, can reduce the amount of left ventricular hypertrophy. So in fact, that patient I showed you right at the very beginning has been on enzyme replacement treatment for 7 years and actually has minimal left ventricular hypertrophy now. And similarly, there are new drugs being developed and trialed for some of the syndromic causes of hypertrophic cardiomyopathy, Noonan syndrome-related disorders with MEK inhibition. And we're also moving into this sphere now with sarcomeric disease. So you'll all have heard of mavacamten. The results of a phase 3 clinical trial were reported at the ESC Congress earlier this year with really promising results for the treatment of adults with symptomatic obstructive hypertrophic cardiomyopathy. But what's interesting to me about these data are that in the animal model, this drug, mavacamten, can actually prevent the development of left ventricular hypertrophy in the mice who are mutation carriers. And so there are, of course, now also a number of new gene therapy approaches being developed and pipelines being developed for this. So I think we're at a stage now where we can maybe start thinking about ways of preventing the phenotype developing rather than just reacting late and trying to stop complications and treat symptoms. And I think in pediatrics, we're uniquely placed to do this. We have populations of mutation carriers with very minimal phenotypes, unencumbered by other comorbidities such as hypertension and diabetes. And so I think for me, in a very biased way, the future in pediatric cardiomyopathies is actually very bright. We have this whole disease pathway available to us to investigate and to intervene on. And I think this brings about opportunities for novel therapies and for truly personalized medicine. So thank you very much for listening, and I'm happy to take questions if there are any. Thank you.
Thank you very much, Professor Kaski. That was a wonderful, thorough presentation. You gave us a very comprehensive overview, and you highlighted the importance of genetic testing and specialized clinics for the follow-up of these patients.